So this morning I got a question from a follower who is doing some cardiology prep and they sent me a test question. So let's go over it. Of course, I paraphrased it for copyright purposes, but it states here a 70-year-old male complains of shortness of breath and chest pain. They have a heart rate of 42, respiratory rate of 30, blood pressure 88 over 60. You have an IV established. On the monitor, you see second degree type 1 AV block. What's your initial intervention? Would you say A, TCP, transcutaneous pacing, B, administer epinephrine, C, synchronize cardioversion, or D, administer atropine? Now, the first thing I want to say about symptomatic bradycardia type patients is a lot of students fumble or drop the ball on this, and I don't think it's their fault. I think it's how it's being taught. Years ago, I used to say cash, right? If for any of you who use cash, chest pain, altered mental status, shortness of breath, and hypotension is what we would consider to be unstable. And everyone always says stable gets medications, unstable gets the jewels. When it comes to bradycardia, I do not treat bradycardia if it is stable. If my patient is a stable bradycardia patient, I basically sit next to them. Of course, we're going to start an IV. We're going to do a 12 lead. We're going to do all that stuff, supportive care. But I'm going to talk to that patient all the way to the hospital where they're going to elect to place a pacemaker in the patient, more than likely. Unless, of course, there's an overdose or something of that sort, then they're going to deal with that. But if it's stable, I am doing nothing. I'm not giving atropine to a stable bradycardia. In emergency care, we only treat unstable bradycardia. When it comes to unstable bradycardia, we start the treatment with atropine. Then we move to pacing and or pressors. Now, this test question specifically mentions a heart block, and there is a distinction between high and low blocks. Now, hear me out. I understand that some of you may work at a hospital and you might work with an ER physician who anything that looks like a slow rhythm, they're throwing atropine at it. Shoot, I've seen ER doctors, as soon as they see a bradycardia, they're dropping 2 milligrams of atropine. Now, that doesn't mean that when we take a exam on standards that we're going to pick answers that we've seen out in the field, right? First off, talk about heart blocks and the treatment of heart blocks. Anything that is considered a high degree block, meaning second degree type 2 or third degree block, these blocks are treated with pacing. And there's a reason behind it. When you give atropine to a patient, atropine affects the AV node and up. So more of the atrium of the heart, if you want to think of it that way. If the patient has a second degree type 2 or third degree block, atropine is not going to be as effective. Now, again, I know you're going to say, well, I work with somebody who gives atropine for second degree type 2 and third degree blocks. It's okay to say that. But I'm telling you right now on exams, whenever we are treating second degree type 1 or a first degree block, as long as this patient is symptomatic or hypotensive, yes, I'm going to assist with treatment. Now, what is that treatment going to be? If it is a second degree type 1 and or a first degree block, I'm going to administer atropine. So be careful on how you answer these questions. Just because, yes, this patient is unstable, I understand that. And a lot of you out there want to say, I want to give jewels. I want to pace this person. That's not how algorithms work. Open up the 2025 algorithm for bradycardia and show me where it says that you're going to pace first on a patient who's unstable. It's not there. It's going to tell you to give atropine before pace. I hope this helps. This answer specifically for a second degree type 1 AV block, what is our first intervention going to be? It's going to be D, atropine.